Yeah, good, good, good. All right. So, again, my name is Dr. Vipul Patel, and I moved from University of Maryland to here 7 months ago. And since I moved here, my work is to get started with my lung transplant program. And I'm very excited to say that we now have approval for the lung transplant. So now we are active center here. So we can start recruiting the patient and transplanting the patient as of today. We are seeing the patients to give them a benefit. Right. So it's a very exciting time for VCU. We are looking for this kind of a program for the last 18 years. VCU has a lung transplant program before, but it was closed down because of the lots of team changes, as well as not able to keep up with the amount of the transplant as well as the outcome. Right? So the program was closed down. And last transplant at VCU was performed in 2006, the lung transplant, and now we are reopening again into 2024, so 18 years, and we are now successfully open. So that's very, very exciting time for us. What made me to come here to Richmond in VCU is, looking for the community to serve. Like where is the need for lung transplant? As I worked in Arizona before, in New Jersey, in Maryland, and now I'm here, I looked around first of all. What are the lung transplant program around where I'm moving, like around the Richmond area or VC? If we look at the patients who are needing lung transplant, who has lung disease that is all the treatment, medical treatment and surgical treatment has failed, meaning that despite maximum treatment, the disease is advancing to this level where it is having a challenging to live a life, having a very difficult quality of life. Like quality of life is very important. So if the patient has the advanced lung disease or end-stage lung disease, those are the patients here in Richmond or east from here. They either have to go to Charlottesville, Inola, or Duke. Duke is also crossing the state border. So sometimes it's not easy for them to go to the places where lung transplant is provided. So now we are open, so we are third center in the state. And what's the importance of this, like having a center in the Richmond, that the patients have ability to see a physician, talk about transplant, learn about the transplant, and have an opportunity to have transplant. For transplant, there are lots of needs, requirements, not for just a patient, but entire family. The treatment is offered to patients that involve the family. What I tell the patients most of the time during my first visit is, look, you are going through a few doctors already. My job is to give you an education for lung transplant. So during my first meeting, which is usually lasts for like about 1 hour or hour and a half long, and I talk about lung transplant. Not much, majority of the time I don't write any, prescription or not major changes, not major tests, but talk about transplant. I let the patients guide their care, and that I'm here to help, to provide the education so the patients make the right decision. Right? So what I do is like help them to understand what is transplant is. And transplant is a journey for a patient, most of the time. It's a big, long journey. But first of all, start with they already have a long path of journey before they hit the transplant from their lung disease. Right? They are having a struggle to have a breath, and majority of the time they are oxygen dependent. They cannot walk more than few feet before they get shortness of breath and they have to stop and they have to go again. But that lead to lots of muscle wasting and lots of other body changes that is difficult to live a quality of life. And many times I ask this question to the patients, like, what is the most difficult part for you to do in a day, in a regular day? You wake up in the morning, tell me the details. And they usually say, oh, showering is the hardest for me to do. And at that point I know that the quality of life is miserable. So oxygen need is very, very important for them. Yet they cannot, despite amount of the oxygen we provide, like 4, 5, 10 liters, up to 10 liters at home, they are struggling to do daily activity. And the other question I ask, like, what do you want from lung transplant? And most of the time, I want my life back. And I ask, like, what does life means to you? Oh, I want to go out, go to mall, go to my, grandson's game, or go to meet my friends. So I don't have to worry about oxygen, worry about my breath, and things like that. So those things are very, very important for a patient point of view. And once the patients are like, those are the questionnaires and the things are performed and physical examination, I give them a vision of what does life look like without transplant and what does life look like with transplant. As lung transplant is, of course, a little complex. Yes. But what we are looking for in the first meeting is trying to build the bond between the patients, not just the patient, the entire family, and the entire transplant team. Like, I'm not working alone. I have entire team with me. The team includes a physician or pulmonologist like me, and I have 2 more pulmonologists. Dr. Apostolus Perales, probably you know a few of them. He is also part of the lung transplant team. And surgeons, psychiatrists or psychologists, infectious disease doctor, social worker, financial coordinator, nurse coordinator. Those are like the entire team that assesses the patient one after another. So in that assessment, the bond is being created. Patients are encouraged to ask as many questions as they can after knowing what is lung transplant. I also encourage the patients to read online as much as they can to know about the transplant. Bring the question. Don't make the judgment from the information on the line, but bring the questions and we can discuss about what's the question they have and discuss about what's the path forward. In teams, when the people of the team meets with the patient, they not only prepare the patient for transplant, but also help them to overcome what are the risk factors that that is lead to bad outcome. So our aim is to avoid bad outcome from the transplant, because transplant is a big surgery. It can have some complications. How to avoid the complications from transplant, right? So we prepare the patient for the transplant surgery. Surgery is big. Many of you don't know or don't know. We cut open the chest this way. Not in most of the some surgeons cut this way, but most of the surgeons cut this way. It's called clamshell incision. Open the chest this way, which is a big incision, and we replace the 2 lungs if there is a 2 lungs. If it is 1 lung, we go in the back from here to there to replace 1 lung each side. Patients can live with normal life with 1 lung. So 1 lung is doable option. My preference is to provide every patient, if possible, 2 lungs. only rarely one lung if I have struggled to get the two lungs, then one lung is okay, right? Most of the patients live about, spend about 2 to 3 days in the ICU and 2 to 3 weeks in the hospital. That is usual outcome. There is no major complications. But what is encouraging me and what is guiding me to be in this field is when I ask the patient same question after the transplant: how is your breathing? Right? How is the breathing compared to the prior to the transplant? And I ask that question after like everything settled down, maybe 2-3 months later. I ask this question, and the answer I get it is most of the time, 90% of the time, patient says night and day. I was like miserable before, and now I can breathe normal. Right? And normal means before transplant, every breath I take, my brain needs to know I'm breathing. My focus is always on my breath. Right? Now, breathing is spontaneous. I don't need to even focus on my breath. Right? So that is very valuable information to me, very good feedback to me. Like, now I'm gonna have achieved a very good outcome for this patient. The patient can breathe normal. They don't need to focus on their breathing. Right? So that is very, very important, that they are able to do activity that they are wanted to do for a long, long time. They are able to, enjoy their life. Sometimes patients send me some pictures. Oh, I went to Pikes Peak and here I am, like 7,000 feet elevation. I never dreamed of doing that when I was struggling with the oxygen dragging behind me. Right? Now I'm able to go to the 7,000 feet, 10,000 feet elevation, or 14,000 feet elevation. Right? One patient actually, it's a true story, that I was working in Arizona, and he before transplant he has COPD and he was struggling with the breath. So he was pulling the oxygen behind him, and he's barely walking 50-60 feet. And he came to me and asked during my first visit, "Doctor, give me lungs and I'll kick butts. Just give me lungs and I'll kick butts." Anyway, so our team decided to move forward to list him. We transplanted him, and after transplant, he was, started doing living normal life. But he was a little struggling with his, muscles being weak and a little bit back pain. So next time he come to, after 6 months, he's like, little back pain. I said, "Are you walking normal?" I said, "No, because my back, fix my back and I'll kick butts." Every time, he's like, come with some kind of excuses. "I'll kick butts. I'll fix this and I'll kick butts." Right? Well, I left Arizona, and usually when physicians move, we tell the patients that, okay, I'm moving, but we don't tell where we are moving, right? So I moved to East Coast in New Jersey, and he find out from the website where I moved, and he sent me a letter after 6 months with his pictures, doing a rim-to-rim hike, which is in Grand Canyon, which is extreme hike, about 4,000 feet elevation down and 5,000 feet up. About 24 miles, 23.8 miles, and he said, put the pictures of himself everywhere, and it is clearly written in that letter, "Remember, I kick butts." Here it is.
That's good. Yeah.
I still have that picture with me in my, but it is very encouraging and gratifying to me to, help out the people who has almost all door closed on them, to bring this kind of a unique opportunity to breathe normal. It is not easy path. It is definitely not easy path for I know most of the patients. I mean, it is lots of things to put as a patient. Initially when I was in transplant 10 years ago, a student, I was thinking like somebody has to die to have new life for you. And that was, I was like, constant thinking like somebody has to die to have new life for you. And it's not true. And what I later I learned, like, no, it is in fact opposite. It's some stranger gives everything about himself or herself to somebody else's part alive in their body. That is transplant. So the patient has to give up everything about themselves to keep that lung alive from some stranger, right? That is a transplant. So the patients have to do a lot of things to reach that goal, right? So I always tell the patients, like, it's a commitment to yourself first. You want to do better. That commitment you have to make it to yourself, right? Then you can, do that. As a transplanting, we are always asking, like, what we are looking for is when we ask jump, you say high, how high, right? That's what we are looking for. But most important is like you have to decide based on the information that you have it, and the information is very, very critical before transplant, right? So it's a one-way street. Like, some patients are like little iffy about that, and they say, I'll go for transplant for my son or my wife. Or you're going to the transplant journey for you first. Okay? If you're doing for other person, it's not for you. So first of all, it's for you. And as I said, one-way street. After transplant, the lung is not going to work for you. You're not going to ask for give my old lungs back, right? It's not going to happen. It's a one-way street, right? So, yeah, it is very, very interesting and important to know about transplant, and that's what I bring here. Lots of experience that I have it, and when I came to VCU. My focus is majority of the Richmond area and the eastern part where majority of the patients don't have access to the transplant center. So as I said, these patients needs to do a lot. Right now, as of today, the majority of the centers, which is Duke and Inoa, they ask the patients to relocate because it's a frequent visits needed, frequent testing needed for those patients. So the patients need to relocate for 1 year, which is hard for a patient and the family both. As I came here into VCU, now the patients don't have to travel alone. They can stay here in their own house and they can follow with me after the transplant. So that's a very, very interesting time for the VCU to bring a lung transplant program here. And in my team, along with me, Dr. Zubair Hasmi is the surgeon, along with Dr. Walker Juliard is a surgical director of lung transplant. And these are 3 or 4 lead doctors, followed by the entire team he has created, and we put forward these applications to get approval from the government. So now we are open center. We are, I think, number 67 or 68 in the state to have active programs for the lung transplant. So that's amazing. Many of the states don't have lung transplant programs. So now we are number 3 in the state of Virginia. That's a very good achievement. And my aim is to, once we start, probably 10 transplants in first year. That is to achieve another approval from the government authorities, which is Center of Medicare and Medicaid Services. And after that approval, every year I would like to have growth of about 15 to 20% in the program volume. And from the beginning, my aim is to have good outcome, quality outcome. That is the major aim. That is from the beginning. But as we're going to grow, as the volume is going to grow, the outcome is going to get better and better as the team getting more and more experienced. As patient has to go through lots of areas of the hospital, from ICU to the floor to the clinic and whatnot. So the entire team members has to get educated about the because patients, the people here at VCU, they have active liver program, they have active heart program, heart transplant and kidney transplant program, very robust. And when I came, like, what's new about the lung transplant? And I was like, lung transplant is mother of all the solid organ transplants. So it's unique. It's more complex compared to other solid organ transplants. And people say, why? Why the lung transplant is much more complex? Like, look, only lung is exposed to the environment. So after lung transplant, you are constantly breathing air in and out, and the lung is a very big organ. So when you are breathing air in and out, constant bacteria, constant viruses, constant protein is going to go into the lungs and get exposed. That can trigger the rejection, right? And the rejection is a major hurdle for any organ transplant, any sort. Compared to liver, kidney, and heart, they are not exposed to the environment. So yes, we have challenging time for us as a lung transplant centers to have outcome not as good as compared to the other solid organ transplant. What is? How do I put in numbers? We go usually by median survival. How long people live after lung transplant? What is the longevity of life? Median survival is like, if I do 100 transplants, how many years the patient, most of the patient lives? Some patient live about 6 months, some patient live 20 years, some patient live 2 years, so what most patients live? So right now the data shows is about 7.8 years with 2 lungs and about 5 years with no lung. Again, it's much better than 50 years ago when it was started. The median survival is 3 weeks. 3 weeks. Most of the people die within 3 weeks. So the lung transplant, when it started in '63, it stopped. In 30 years, only 38 transplants happened in the entire world. 63 first transplants, 83, up to 83, only 39 transplants, and the median survival is 3 weeks. Now, for last 30 years, 40 years, we are able to see that growth of outcome is much better. 7.8 years, which is good outcome, right? And majority of the patients, they don't make it to many years. Like when I transplant young people, like cystic fibrosis is the disease where the people have damage to the lung because of the frequent infections in the kid. They becomes now adult and they need a lung transplant at the age of 25, 30. They spend only 7-8 years with the lung transplant. So they don't live long life, right? Because of rejection. Lung transplant is a very complex organ immunologically. Rejection is a major coding factor for us. And that's the reason why we are very vigilant in having a care for the patients after the transplant. We frequently see the patient every weekly, every 2 weekly, every 3 weekly, then it goes on up to every 1 monthly. At the end of 1 year, we frequently do the bronchoscopy and biopsy to look for early rejection treated. So that's very hard for the patient, yet the rejection is a major holding factor for us to have a longevity. So that's why I'm telling this. Most of the people, lung transplant is the mother of all the transplants compared to other solid organs. Right? So Yeah, I'm fortunate to be, in pulmonary critical care and cardiology or hepatology to do liver transplant, because it's fun for me to, how do I provide more and more for the patient, and have opportunity to learn more. That's what I'll bring here to the ECU, and the hospital has provided me lots of support to develop this, and I'm very, very happy to be here. Right, thank you. Questions? Yeah.
What is the source of, where do you get your lungs?
Could you repeat the question so the people remote can hear you?
Sure. So the question is, where do I get my lungs? What's the source of the lungs? Where are the lungs coming? And it's funny that, good question that you asked, and it's funny in a way that many times patients come and say, why don't I get the lung transplant? I say, no, lungs are not made in the factory, right? Lungs, we get it from the people who donate their organ after their death. And they die because of some other reasons other than the lung. Majority of my donors coming, they are either died because of the brain issues, like stroke or brain injury or motor vehicle accidents or IV drug abuse, and they stop breathing, and those are the donors that I get. Sometimes drowning, they drown and they close off their glottis. The water didn't went in the lung, but yet they died because of the drowning. Sometimes we get those kind of lungs too. So yes, the donors usually younger, between 18 to 55 years of age, that we get the lungs from, and we get the lungs from everywhere in the states. That's the system that we are using to have organ offer from. It's called United Nations Organ System. UNOS. UNOS is the organ providing organization, and we get the lungs from anywhere into the other part of the state. Sometimes we have to fly out to North Carolina, Massachusetts, Kentucky, wherever the lungs are.
Can you get a lung from two different people?
Can you get lungs from two different people? Yeah, you can get a lung from two different people, but once you get one lung from one person, then you are no longer eligible for a second lung transplant, like 2 days later or 3 days later. If I have donor at the same time, I would rather not do it, because if you can get the lung from two different people, two different immunological issues that can come. So it's going to be very complex, like the rejection rate is high. So I would rather have two lungs from one person than two different lungs from two different people, right? My immune system is going to fight against each different sets of the lung. It is not good. So,
are there certain commonalities that the patient and the donor have to have for a lung transplant?
Right. So, that's a very good question. Are there any commonalities or similarities of the donor and the recipient? So, we match the recipients and donor from the blood type. The blood group A, blood group B, what we know, we have to match that. The patients from blood group O can donate the organ to any patient's blood group. AB has to go to blood group A. That way we match the AB blood group. We also match the tissue typing called HLA, human leukocyte antigen. There is a special lab here in the Richmond that matches the donor and recipient. Like sometimes we get the donor blood here, and we match the recipient blood, which is the patient's blood, and see whether this is proper match. All right. So any patients who are going to be listed, their blood is already sent to the HLA lab and have a match ready to go. Right? Because we don't know at that time who's the donor. But once the donor information is there, we match it at the same time, right? Along with the blood type and the tissue matching, we also have to match the size of the lung. Like the chest cavity is small or big based on the disease, based on the person's height, based on the sex of the person. Like woman has a smaller cavity compared to men. So if I have a patient who is a 5-foot woman, and I get lungs from 6-foot man, I'm not gonna fit that lung into the woman. So I had to let go that lung, and then I have to wait for the next donor who's a 5-foot woman. Okay?
Sometimes if the lungs are close enough and the patient's getting desperate, they sometimes shave the lungs.
Right, so you can do that, like you can cut small part of the lung to fit the lungs in the cavity, or it's not exact match you need, it's just roundabout close match you need, because lungs are spongy structures, so it can fit in the cavity if the size is like somewhat like close to the chest cavity, right? So yeah, sometimes we have to cut part of the lung, which I personally don't like. Surgeons can do it. Surgeon has technique to do it. I personally don't like it because not only the part of the organ is go away. It's fine because lung is a big structure. You can live normal life with remaining lung, but it can generate rejection because it exposes the tissue to the blood. Right? So when you're cutting the lung, you try to minimize that to expose the immune system exposure. Right?
Is there a plentiful supply of lungs, or is there a shortage of lungs?
Very much shortage, very short. Like if you compare the other solid organ transplant, lung is the least available organ because in any donor, the lung is damaged very quickly. They have aspiration of the gastric juices, they have ventilator issues, so the lungs get damaged much more quicker. The question was, is the lungs available quite often or short?
What is the shelf life of the lung?
Shelf life, after death, we have 6 to 8 hours to put it in the lung.
Wow.
So once we remove the lung from the donor, we have 6 to 8 hours to put it in the end of the patient. So at that time, team works in the tandem with each other. One team goes out to get the lungs, other team opens the patient here and get ready. When the team brings back the lung in the OR, we quickly suture it in. So that communication is extremely important at the time of transplant. And two surgical team needed. One is procuring team that goes out and get the lungs. Another team is going to be opening the patient and implanting the lung. So 6 to 8 hours is the time that we are looking for.
So the same team, your team, part of that team goes out and recovers the lung.
Yes.
And the other team is here
Yes.
opening
Yes.
the receiving side.
All right. So for each transplant, there are 2 surgeons needed. One is procuring surgeon and one is implanting surgeon. So 2 surgical team needed.
So there's hopefully no surprises.
Right. Smoking related damage to the lung called COPD or chronic obstructive pulmonary disease, which damages the lung. Along with sometimes sarcoidosis, probably you heard about it. Sarcoidosis is inflammation in the lung, unknown reason. Some patient, unfortunate people have that inflammation, causes damage to the lung. That sarcoidosis more commonly we see in Black Americans than white Americans. Cystic fibrosis, which is the genetic disease where the kids born with some abnormalities in their genes that lead to the damage to the lung, and more commonly seen in white Americans, and pulmonary fibrosis, which is one of the big now. for last 10 to 15 years, more and more patients with the idiopathic pulmonary fibrosis or pulmonary fibrosis, in which the scarring occurs in the lung without any reason, unknown reason, that what we say. That's why it's called idiopathic, and that leads to damage to the lung. And the damage is much more fast progressive. So any patient with the pulmonary fibrosis, we tend to be more aggressive to put them on the list because they have very steep decline in their lung function once they're diagnosed.
And you have a lung transplant, you on top of lung disease also have vasculitis of the lungs. You still have a lung transplant because that is an autoimmune disease, so wouldn't it attack the new lungs?
Right. So can you have a lung transplant when you have autoimmune lung disease, like lupus, rheumatoid arthritis, vasculitis? Those are the inflammatory lung diseases, right? Autoimmune lung disease. Yes, the patients can have a lung transplant, and usually they don't have recurrence of the disease in their transplanted lung after the transplant is over, because the patients are on heavy immunosuppressive therapy, so the inflammation is going to be much more controlled.
Okay.
So many patients with the autoimmune lung diseases who has damage to their lungs because of that, they get the lung transplant and benefit from lung transplant.
And I find that it's much faster progressing than just having lung disease, because I have lung disease and I have vasculitis of the lungs. So.
Right. I mean, it depends on what that autoimmune disease causing the lung. Is it scarring or is it pulmonary artery hypertension? So pulmonary artery hypertension is another disease that requires lung transplantation, in which the pulmonary pressures in the lung vessels is higher. Unknown reason at times, sometimes autoimmune diseases causing pulmonary artery hypertension, and the lungs started getting damaged. You have difficulty breathing because of X-ray and the CT scan can be normal, but the heart is struggling to pump the blood to the lung to get the oxygen and carbon dioxide exchange. So yes, those patients can benefit from lung transplant.
Jerry, you talk about autoimmunity being the big bully as far as longevity after. Is there any medical advancements on the horizon that may help deal with that immunity issue?
Right. So in autoimmune disease, any medical advancement happen to prolong the life without lung transplant, right? Yet there is constant research going on to improve that, and there is always struggle to find a proper therapy. Most of the therapies are immunosuppression therapy.
Right.
So the struggle is, when you are putting the immunosuppression, infection risk is higher and all these things. So always there is advancement happens, and it is the specialized doctor who does work in the autoimmune lung disease. They can help us at times to answer such questions for the patients. I don't know the exact answer, like any special new medication developed in last few years or no, because I'm focused in lung transplant. But whenever we have questions,
the rejection of new transplanted lungs.
right? So that was also developed in last few years to develop immunosuppressive therapy
Right.
to prevent rejection.
Okay.
But it's not 100%. 100% like helps to avoid rejection. With that immunosuppressive therapy, we are able to move from 3 weeks to 7 years,
Okay.
right? In 30, 40 years. That is the advancement of immunosuppressive therapy. But yet we are very much behind the compared to other solid organs. Patients has to go through the immune suppressive therapy after lung transplant. That's what the care is about after transplant. Yes.
I go to VCU to see Dr. Perlis, and he's been sending me to UVA for the lung transplant program there. And they seem to think that next month I'll be listed. But now the charter program here, is it possible just to get listed at 2?
Yeah,
basis
it's a very good question. I mean, can you get dual listed?
at both places?
Center?
or-
Yes, you can get dual listed, and it's a very. I think that most of the insurance company won't you know make any difference. I mean, you are allowed to have dual listing. Couple of things that you have to know is whether I'm going to get advantage being dual listed at the center. Like, when I was in University of Maryland, Hopkins is 5 miles away, right? So the patients come sometimes waiting for the lung transplant at Hopkins. Hey, you are at University of Maryland. I noticed that you are a little more aggressive than Hopkins. Can I dual list there? And I say, yeah, you can, but advantage to get dual listing is going to be go away because the centers are too close to each other. So the catchment area for the donor is the same for two centers. If you are your centers, two centers as far as possible, that would be going to be beneficial to you because catchment area is going to be different for two different centers, right? So that's one. And the second thing that you have to also know that if you are dual listed at two centers, you have to be available to reach the center when the transplant is going to come. You have to reach to the center in time. Most of the time, I tell the patients all the time, like, don't rush to go to the hospital when you get a phone call. Hey, we have a lung for you. Come on, get admitted in the hospital. Don't drive 150 miles an hour to reach the hospital, right? Take your time, be safe, drive carefully, reach the hospital, and then you're going to have to wait till the team is going to go there, assess the lung, and then when they're ready to bring the lung back, then you're going to go to the OR, they're going to open the chest, right? So that's what happens, like you have to be available to reach to the centers within the time. Most of the time at DCU, I prefer to be available, patient to be available within 2 hour radius, 2 to 3 hour radius, right? So that's okay for me. But if the patient lives 5 hours away, they cannot reach in time to the center when the time comes. I usually ask them to relocate, right? Or find a center closer to them. That's beneficial for them, right? I have also patient who lives in the other state and they are dual listed when I was in Arizona, because Arizona is desert everywhere and Phoenix is the big place there where the transplant center where I was working. And the patient wants to dual list, so either they go to the California in LA area, which is 6 hours away, or in Texas. When they dual list, I had to ask, like, how are you going to reach to the center when there's a donor? They say, okay, I have Mediflight ready. So anytime there is a donor, they fly here to the hospital within 2 to 3 hours. So Mediflight is also available if you have ability, if you are listed at the transplant center, which is farther away. So yes, dual listing is possible.
So this all is very expensive.
Yes.
And does your insurance company limit you?
So most of the time, insurance like the question is this expensive endeavor and insurance company limits you? Well, that's going to get checked before the transplants. Like, there is a assessment with the financial coordinator with you to make sure that you have it's most of the time we don't limit ourselves for the transplant surgery, because transplant surgery is one cost. But more importantly is, can you continue to get medications after transplant? Can you continue to get immunosuppressive, which is quite a bunch of medications to make sure that the lungs remain safe in the patients. Like, patients have good outcome. They should not have a bad outcome because medication stopped from the insurance company. Right? So insurance company has to continue the care after the transplant.
5 years?
Right. 5 years, 7 years, whatever the number of the years the patient is going to live. Sometimes 10, 15 years. So that's what we are looking for. That insurance company, not the cost of the transplant surgery, but cost of medication after the transplant and continued care.
So, you know, if you evaluate it ahead of time, and you talk to the patient about the costs, and they check with their insurance company, I mean, is there other sources of ways to pay for all of it?
Yes.
Besides just your insurance company?
All right. So sometimes the patient few of my patients came with the cash pay. Again, not my alley of work, so I don't know much
How
detail.
much?
Again, I usually don't know much detail about it, but I heard the number around 1 million for the surgery. Alright, so I know it's hard, but it is. Some people can afford it and can go for it, but also some people have insurance with some donut hall or some kind of co-pay, and whether they are able to afford that much amount of the pay. Some people need to raise the money to reach to the.
I could sit here and just listen to your education a lot longer. I really could, but you have been gracious. Thank you.